Hello, good morning. I'm Dr. Ignacio Montaño Callejas. First, I would like to thank the Chilean Society of Cardiology and Cardiovascular Surgery for having invited me to participate in the Annual Pediatric Cardiology Course. This time, I will present screening for congenital heart diseases in the fetus. Congenital heart diseases are the most common malformation, with an incidence of 8 to 10 per thousand live births. They are the least diagnosed and account for 30 to 60% on the 20 to 24-week ultrasound. In highly experienced centers such as Madrid's Hospital 12 de Octubre, Dr. Alberto Galindo has a 65% sensitivity for diagnosing heart disease in the 21 to 24-week screening. Another group from Dr. Carvalho has a sensitivity of 75%. At the local level, for the prenatal diagnosis of conotruncal heart defects at Hospital San Jose and the Northern Hospital Complex, Hospital Roberto del Rio, we have a sensitivity of 99% and a specificity for conotruncal heart disease of 65%. In the Clínica Indisa group, where we participated in a 5-year study, the prenatal diagnostic sensitivity and specificity for congenital heart disease for both major and minor heart defects were 58% sensitivity and 99% specificity. Heart defects are 6 to 7 times more common than chromosomal abnormalities and 3 to 4 times more common than CNS malformations. They are also important because of their impact on neonatal morbidity and mortality. It has an overall mortality rate of 25 to 35%, with 60% occurring during the first year of life. It accounts for 20 to 30% of neonatal deaths and 40–50% of infant mortality. Heart diseases are associated with chromosomal abnormalities in 25–50%, with monosomy X in 40%, with trisomy 21 in 50%, and with trisomy 13 and 18 in 80–90%. Even when the heart disease presents in an isolated form, the risk of aneuploidy is 15 to 25%. The ISWAC guidelines were updated in January 2023, and the guidelines propose that the outflow tracks should be included in the 21 to 24 ultrasound, together with the 4-chamber view in the 21–24 morphology ultrasound. It seeks to detect cardiac abnormalities, as well as cardiac function and heart rhythm. The ISWAC guidelines are based on the 5 views proposed by Simche-Yagel. These are transverse views that begin at the level of the upper abdomen and end in the upper mediastinum, abdominal situs, 4-chamber view, 5-chamber view, 3-vessel view, and 3-vessel trachea view. Here we can see the abdominal situs, 4-chamber view, 5-chamber view, 3-vessel view, and 3-vessel trachea view. The abdominal situs is the first view to assess the visceral situs. The stomach is seen on the left, the aorta on the left posterior side, and the inferior vena cava on the right. That is the abdominal situs. There may be mirror images when we are dealing with the situs inversus, where the stomach and the aorta will be on the right. That would be situs inversus. We can also find in the abdominal cross-section, we see the aorta and the vena cava side by side. And on the right, we would be looking at a right isomerism, which is also associated with complex heart diseases. And when we see on the abdominal scan, 2 vessels side by side, the aorta and the interruption of the vena cava with azygos continuation, we would be looking at left isomerism. When the unpaired organs are neither situs inversus nor situs solitus, it is called situs ambiguous or heterotaxy syndrome. Here we can see right heterotaxy, and on this side, left heterotaxy. The 4-chamber view has an axis that points to the left with an angle of 45 degrees plus or minus 20 degrees. It occupies 1/3 of the thorax. All 4 chambers should be visible, and there should be no pericardial effusion. Here we have an apical 4-chamber view where you can see that the atria and the ventricles are the same size. The left atrium is posterior, the foramen flap opens to the left, and you can see the entry of the pulmonary veins. The atrioventricular valves have a differential insertion. The tricuspid valve is more apical than the mitral valve, and you can see that the ventricles are contracting. Good ventricular function. Here we can see that the atria are the same size. We can see the pulmonary veins entering the left atrium, and the foramen flap opens from right to left. The ventricles, 2 ventricles of the same size, show no hypertrophy of their ventricular wall. The moderator band is located at the apex of the right ventricle. The interventricular septum has to be intact. The atrioventricular valves, the crux of the heart, has to be undamaged. Both open and move freely. Differential insertion of the tricuspid valve. Its septal leaflet inserts into the septum and toward the apex. It is important to assess the rhythm. The normal rate fluctuates between 110 and 180 beats per minute. There may be transient bradycardias and tachycardias in the second trimester. Among arrhythmias, premature beats are the most frequent and generally benign. Tachyarrhythmias and bradyarrhythmias can progress to severe forms. The heart rate must be recorded by simultaneously recording the atria and ventricles and assessing that each ventricular contraction is preceded by an atrial contraction. If we only obtain the four-chamber view during the exam in the general population, detection is only going to be 30 to 40%. When we perform the four-chamber view and the outflow tract view in the general population, detection will increase to 60–70%. The outflow tracts are vessels of equal diameter. They emerge from their respective ventricles and they cross at a right angle after their origin. As you can see here, the aorta emerges from the left ventricle and the pulmonary artery from the right ventricle. They cross immediately. The technique to perform the evaluation of the outflow tracts, the three-vessel view, and the three-vessel and trachea view. There are three ways. The first one is when the heart is in the apical four-chamber view. Angle the transducer toward the head, and we're going to see the four chambers, the five chambers, the three vessels, and the 3VT. That's the sweep. The second, when the heart is in the lateral four-chamber view, is to rotate and angle the transducer to the right, and the last is to slide the transducer toward the head. They will allow the identification of the outflow tracts and 3VT. Here we see the five-chamber view, the long axis, the aorta emerges from the left ventricle. It can be seen that there is continuity of the septum with the anterior wall of the aorta and continuity of the posterior wall with the mitral valve leaflet. Aortic septal continuity and mitral aortic continuity. We can evaluate the semilunar valves. They open in systole and close in diastole. Their normal appearance and disappearance can be seen. The right ventricular outflow tract, three vessels. Here you can see the trunk of the pulmonary artery, the aorta, and the vena cava. From left to right, pulmonary, aorta, vena cava, the PA with its converging branches. Finally, we move toward the superior mediastinum to reach the three-vessel and 3VT view proposed by Jaegel. Here we see, from left to right, the ductal arch, the aortic arch, the transverse, the vena cava, and the trachea. The ductal and aortic arches are going to be positioned to the left of the trachea and form the V, and to join, they converge at the level of the descending aorta. Under normal conditions, there must always be antegrade flow, from anterior to posterior. The outflow tracts, the three vessels, and 3VT are going to improve the detection of heart defects, especially conotruncal heart diseases and malaligned VSDs. Truncus arteriosus, TDA, tetralogy of Fallot, double outlet right ventricle. These can be diagnosed using the outflow tracts and 3VT. Here we have an example of a double outlet right ventricle, where two vessels can be seen emerging from the right ventricle, the anterior aorta, and the posterior pulmonary artery. Two vessels side by side in a shotgun barrel view, and here two vessels in the 3VT view because it is transposed and the pulmonary artery is below. Here we see again, this is a case that went to term and corrective surgery was performed. In addition to the double outlet right ventricle, it had an aortic coarctation that was repaired and an arterial switch was done at 6 months. In the tetralogy of Fallot complex, here you can see the aortic override over the interventricular septum. You can see the subaortic VSD and the arterial trunk. And transposition of the great arteries, when you see that the pulmonary artery emerges from the left ventricle and goes toward the postero-inferior direction, and the shotgun barrel sign. The updated ISWAG guidelines on cardiac screening have a checklist to record everything that has been performed in cardiac screening, including the general section, atria, atrioventricular connections, ventricles, the left and right outflow tracts, and the three-vessel and three-vessel trachea views. What factors influence the prenatal diagnosis of congenital heart diseases? There are factors that work against it, such as maternal obesity, transducer frequency, abdominal scars, amniotic fluid, both polyhydramnios and oligohydramnios, fetal position, and the transverse anterior back position. Of all of those, the one I would recommend the most would be experience and the time devoted to the examination. How are we going to improve? With ongoing training, with courses, with a fetal echocardiography workshop, the possibility of referring for an echocardiogram, fast access, a fetal heart specialist or a consultant, and receiving feedback. Dr. Lindsay Allen, who was a pioneer of fetal cardiology, said that the prenatal diagnosis of heart disease depends on the technical ability to obtain conventional cardiac images, which is achieved through practical understanding. Recognize and accurately describe the differences between normal and abnormal. In 2020, a group of doctors from the Netherlands published a paper on why congenital heart diseases are overlooked. The goal is to identify causes that lead to diagnostic suspicion being missed in second trimester screening. 49% was due to a lack of adequate acquisition skills. They did not obtain the required views, they did not know them, and therefore they did not diagnose the heart defect. 31% made all the cuts, but the defect was not recognized. And 20% is the inevitable loss. That is to say, the heart disease is present, but since it is progressive, it will manifest at term or after birth. The diagnosis of heart disease can be improved by increasing the number of exams performed by each sonographer per year. A higher exam volume contributes significantly to the prenatal diagnosis of severe congenital heart defects. Color Doppler becomes a fundamental tool that will allow us to obtain signs, clues, and key information to improve the diagnosis of congenital heart diseases. Color Doppler is essential to confirm normal patency conditions throughout the heart. Blood flow in the expected direction, assess the direction of flow in the interatrial septum to rule out ventricular septal defects, and also rule out valvular regurgitation of the atrioventricular valves. Rule out turbulence if present to find or confirm small vessels. Color Doppler will shorten the exam in patients who have increased body mass. It will give us confidence during the exam, and it will allow us to improve our cardiac screening and improve our diagnosis of congenital heart disease. Here we have the three-vessel view with anterograde flow, always the same color from left to right. Here we see, in grayscale, the left ventricular outflow tract with antegrade flow and color Doppler in the lateral four-chamber view, applying the ultrasound beam perpendicular to the septum to detect ventricular septal defects. Here we can see color Doppler using the stick volume, where an apical four-chamber view and a lateral four-chamber view can be clearly seen. We can also see the aortic arch, the drainage of the vena cava, and here we can see the pulmonary veins reaching the left atrium. 3VT, color Doppler interrogation. Pulmonary veins. Normally, you have to evaluate the pulmonary veins both in grayscale and in color Doppler, and make sure that at least two pulmonary veins reach and enter the left atrium. The aortic arch is seen on sagittal slices. We can see the aortic arch with its supra-aortic trunks, the brachiocephalic trunk, the left carotid, and the left subclavian artery, aortic arch. And we are also going to evaluate the straight ductal arch that runs from anterior to posterior, like a golf club or a hockey stick, the aortic arch, and the drainage of the pulmonary veins. Color Doppler will also allow us to identify the filling of the cavities. When, in this case, homogeneous laminar flow is observed, it fills during diastole. And here we have a complete application of color Doppler, where we see the filling of the chambers and the outflow through the outflow tracts of the aorta in the three-vessel trachea view. The ISO guidelines have become more demanding. Both the American Institute of Ultrasound and the Fetal Medicine Foundation say that during screening at 11 to 14 weeks, we should perform an abbreviated early cardiac screening, four-chamber view, and the three-vessel trachea view with color Doppler. Both the American Institute of Ultrasound and the Fetal Medicine Foundation say that during the screening at 11 to 14 weeks, we should perform an early cardiac screening, the 4-chamber view and the 3 vessels and trachea view with color Doppler. And the technique is the same, the 5 Yagel views, but summarized into the 4-chamber view and the 3 vessel and trachea view. Color Doppler will allow us to look for signs and clues to diagnose congenital heart disease. Here we can see classic signs, the Y sign in the fallocomplex, the butterfly sign in the fallocomplex of the type with agenesis of the pulmonary valve leaflets, the twig sign or venous collector sign in total anomalous pulmonary venous drainage, the little balloon sign in critical aortic stenosis, and the 2-vessel skateboard sign in the 3-vessel trachea view. The shotgun barrel sign also at the TJ. Newly proposed signs. The horseshoe sign, which is the normal 4C, and the mountain sign, which would be 5 chambers plus the transverse aortic arch. That would be the usual. And the new sign for transposition of the great arteries would be the sea lion sign, because of its resemblance to a sea lion, since the pulmonary artery emerges from the left ventricle and goes toward the postero-inferior direction. These are the normal signs. 4 cameras, mountain sign. As we were saying, the Y sign, the butterfly sign, and the branch sign, a confluent vein or venous collector in total anomalous pulmonary venous drainage. Altered horseshoe sign with single ventricle flow in left ventricular hypoplasia. And the classic signs, the skateboard sign, the shotgun barrel sign, anterior aorta, posterior pulmonary. There is also another classic sign, which is the H letter sign, incomplete atrioventricular canal. Balloon sign in the context of critical aortic stenosis, a globular left ventricle with limited mobility, distended with echogenic walls due to endocardial fibroelastosis. The indications for fetal echocardiography. Most indications for echocardiography are due to a suspected cardiac anomaly or malformation on the 21-24-week ultrasound. Here are all the recommendations from the updated 2C23 SWAG guideline. Critical congenital heart diseases are those that will require invasive surgical medical treatment in the first month of life. Ductus-dependent when the systemic to pulmonary circulation depends on the ductus. CHD with a high risk of hemodynamic instability requires immediate stabilization after birth or intervention in the immediate postnatal period. These include transposition of the great arteries with a restrictive foramen ovale, hypoplastic left ventricle syndrome with a restrictive foramen ovale or an intact interatrial septum, obstructive anomalous pulmonary venous drainage, Ebstein's anomaly with fetal hydrops, tachyarrhythmias, and bradyarrhythmias. I'm going to refer to congenital heart diseases, and I'm not going to cover arrhythmias as part of this presentation. Here we have an example of a transposition of the great arteries that was diagnosed at 14 weeks. You can see that the vessels originate in parallel, side by side. Here we can clearly see what's called the skateboard sign. This is a transposition of the great arteries that unfortunately first presented with severe preeclampsia at 31 weeks. An emergency cesarean section was performed at 31 weeks and surgery was done at 1 month, but the patient died after the procedure. Another case, left ventricle hypoplasia. Here we have severe hypoplasia of the left ventricle. There is only univentricular flow. There is hypoplasia of the LV, mitral atresia, aortic atresia, and mitral atresia. And here in the 3VT view with reversed flow in the aortic arch. When this patient was 38 weeks pregnant, you can see it there on the 3VT view, on color Doppler, the hypoplastic aortic arch with reversed flow. This patient was able to carry the pregnancy to term at 40 weeks, labor was induced, and she had a normal delivery. Subsequently, it became hybrid, and then the Norwood. Anomalous pulmonary venous return. Here we can see a case of infradiaphragmatic anomalous pulmonary venous drainage. And what I'm going to show you here is the branch sign, which is the venous collector that is located behind the left atrium. Here you can see the branch sign in grayscale, and here you can see the branch sign on color Doppler. And here we're going to see that there is a vertical vein that passes through the diaphragm and goes toward the portal vein. The vertical vein crosses the diaphragm and has high velocity, continuous, turbulent flow in the portal vein. Here we can see the infradiaphragmatic anomalous venous drainage, which is obstructive. Ebstein's anomaly is when there is a displacement of more than 8 millimeters per square meter of the septal and posterobasal tricuspid leaflet toward the apex of the right ventricle. There is hypertrophy and thinning of the wall, atrialization of the RV, depending on the degree of cardiac dysfunction. There is holosystolic tricuspid regurgitation, assessment of right ventricular outflow tract obstruction, and right ventricular function. Ebstein's anomaly with a poor prognosis has a 45% mortality rate with progressive dilation, right-sided cardiac dysfunction, CHF, hypoplasia, stenosis, and pulmonary atresia. This is a case we received at San Jose Hospital with severe Ebstein's disease. They had severe TR, hypoplasia of the pulmonary trunk and branches, and reversed flow in the ductal arch. We had seen this patient at 30 weeks, and at 34 weeks, they told us that she had a stillbirth. The prognosis of fetal heart failure can be assessed with a score called the Huta cardiovascular profile. This is a normal score of 10 points, and treatment with digitalis is indicated at 7 points or less when there is no hydrops, and at less than 5 points with hydrops, high perinatal mortality, and treatment must be carried out. These 5 categories of the cardiovascular profile with a normal score of 10 are as follows: hydrops, venous Doppler, heart size, cardiac function, and arterial Doppler. In 2022, at the Congress of the Chilean Society of Ultrasonography in Medicine and Biology, we presented a contribution on the prenatal diagnosis of congenital heart disease, correlating the diagnosis of major conditions prenatally and postnatally over a 2-year period. In our results, we found 48 cases of major heart defects. 38 were diagnosed prenatally with a 100% correlation for aortic coarctation, a 20% correlation for total anomalous pulmonary venous drainage, and the latest gestational age at which the diagnosis was made was in the 2nd trimester on the morphology ultrasound. All recommendations: any pregnant woman with a critical congenital heart disease, delivery must take place in a tertiary hospital. Communication with the multidisciplinary team will have a beneficial impact on the newborn's prognosis. The completion of the pregnancy. The goal is to reach full term. Cervical length measurement is not standardized in a protocol. The management of threatened preterm labor must be followed according to the protocol. Corticosteroids, tocolysis. Indomethacin is contraindicated because it closes the ductus arteriosus. Never use indomethacin in congenital heart disease, especially if it is ductus-dependent. In the event of imminent labor, neuroprophylaxis before 32 weeks. Fetal monitoring after 38 weeks every 7 days. Timing of interruption or resolution if it is a mild heart disease at 42 weeks, if it is a ductus-dependent heart disease at 40 weeks. And also perform an obstetric ultrasound to monitor the fetal growth curve. Always prioritize a vaginal delivery, a cesarean only for an obstetric reason or in case of FGR or a fetus with heart failure. Minimize the risks of loss of fetal well-being. Plan resuscitation and stabilization of newborns. Try to predict the risk of hemodynamic instability, ductus-dependent congenital heart disease, or the need for atrial septostomy if prenatal cardiac dysfunction is present. Heart diseases that cause volume overload, rhythm disturbances. If there is a respiratory system abnormality, bronchial compression as in the Fallot complex, such as agenesis of the pulmonary valve leaflets. Presence of markers of fetal compromise, FGR, abnormal fetal Doppler, and hydrops. 3 categories of risk of hemodynamic instability at birth. 1. Congenital heart disease without risk of hemodynamic instability. 2. Non-congenital heart disease with a low risk of hemodynamic instability. These are the ductus-dependent ones. The newborn will be stable until the ductus arteriosus closes, and here are left ventricular hypoplasia, aortic coarctation, severe aortic stenosis, interruption of the aortic arch, pulmonary atresia with an intact septum, and severe tetralogy of Fallot. These have to be born at the tertiary hospital and start on prostaglandin. Lastly, we have critical congenital heart disease with a high risk of hemodynamic instability. Newborns with suspected ductus-dependent congenital heart disease are treated with prostaglandins to keep the ductus arteriosus patent and maintain hemodynamic stability until a cardiology evaluation is performed at the receiving facility. Low doses of prostaglandin are able to keep the ductus patent with a very low risk of causing significant apnea. A physical examination before discharge is important to look for cyanosis, heart murmurs, or decreased asymmetry of the brachial and femoral pulses. A cardiology evaluation, pulse oximetry, and screening for ductal-dependent congenital heart disease should be performed. Postductal oxygen saturation, or a 3% difference compared with preductal saturation in the right hand, will require a cardiology evaluation. The American Heart Association proposes or recommends fetal predictors for delivery planning, and here we can see where they are summarized for each of the critical congenital heart diseases or conditions. For example, when faced with a ductus-dependent heart defect, be prepared for prostaglandin infusion. In the case of hypoplasia of the left ventricle with a restrictive foramen, plan for a possible urgent intervention to decompress the left atrium, balloon catheterization, or a surgical stent. Also, in dextrotransposition of the great arteries DTGA with a restrictive foramen, plan for an atrial septostomy, that is, an urgent balloon procedure if possible in the delivery room or ICU, and also initiation of prostaglandin. And we also see here for tachyarrhythmias, for example, if the pregnancy is already at term, to consider delivery and urgent cardioversion or medical therapy in the delivery room if possible. Here in this table, we have all the recommendations for management after delivery. 1/3 of congenital heart diseases are severe and will require a surgical intervention in the first year after birth, and they will affect these children for their entire lives. Prenatal diagnosis of CHD reduces mortality and perioperative morbidity and improves these children's neurodevelopmental outcome. Thank you for your attention.